Hello everybody, this is Giuseppe Romeo speaking. This is the second part of the presentation that most of you they had a chance to see online through Dr. Claudio Fernararo and my own Facebook page as well. So we finished last time with the provisionals. We made a lingual stop, and what we did in the laboratory, the clinician is going to continue the same procedures because he got a file, a keynote file, that he has to follow all the steps what the laboratory did, so he can follow at the same way and try to make the preparation, the suitable preparation, to get together the final aesthetic result. So let's start with the dilemma of the situation, that is the canine. It's a bulky canine, it's very prominent, and so we are going to measure the mesial distal sides of the tooth, and we try with the silicone key that we use in the laboratory to see if they can fit it in the mouth the way the dentist has to cut the tooth. So there is a big prominence of the canine, so for sure the first part that we have to cut it is the two canine and the facial area. Once we did that, we can see also the size and the length of the tooth, but we starting in the beginning with the canine, so we grind facially in the beginning and then mesially and distally. Everything when we starting to prep, then we check with the silicone key if we wanted to stay in the configuration of the tooth that we projected in the beginning in the laboratory. So after that, we decided to the suitable configuration of the preparation. We try with the silicone key. We want to fit the silicone key, and we can see on the facial, especially you can see the pictures on the left side, there is just a little bit of space and we need just a little bit more, but we don't want to get the dent in. We want to stay in the enamel for the suitable and an efficient bonding after the veneers will be cemented. So mesially and distally, we need a vertical prep, and it's an interesting preparation to manage the shape of the teeth, both in crowns and veneers. So with the disc and with a flam bar, and then with the silicone guide that the laboratory did. About the preparation of the veneers, so the dentist has to put it in the mouth and see in which way he's going to fit it to stay on the same wavelength and to get together the final aesthetic result. So once we did that in these conditions, so we have a good possibility to stay very close when we projected in the beginning with the wax up. And then there's the design, the prep design. That is very important. So we know that we need to reduce from 9 millimeters to 7 millimeters to stay in the range of the canine. So the dentist moved the soft tissue with the flame bars. He used in the beginning these diamond bars, but I really recommend to use a flam tungsten bars that is going to be more vertical in its preparation. So the dentist is working mesially and distally, checking the silicone key, the way this is working, and then he's going to get an impression. The laboratory is going to developing all the model work that he needed. So he needed a solid model and a section model with the tissue, and this model work allows the dental technician to condition also internally the soft tissue to give also cervically the final design. And then we go and moving to the ceramic, the way we're going to layer ceramic. On the two centrals, so we made a butt margin. We didn't prep the two centrals because we didn't need to have preparation on the centrals. So we needed to have 0.2, 0.3 incisally to create more space, just to allow the ceramic to have a little bit of thickness that gives to the future veneers a strength during the cementation. But it's important that when we put the incisal wall, has to stay in this case more lingually as we can. After that, we can put modifiers and color effects in ceramic, and we layer little by little. We don't layer all the tooth, but we want to see the first perimeter configuration of the tooth in the beginning. After that, we can block the colors, we can check with the silicone key, and then we can layer on top with different enamel of translucency and opalescence enamel that gives to the patient for the final rehabilitation the suitable effects. Also for the canine, that was very difficult, so we work more lingually for the incisal wall. We decided just with a little bit of dentin, just don't change too much the value and don't see an aesthetic gray line zone area after the cementation. So we work with just a little bit of dentin. We put enamel and different kind of translucents on top of the incisal area. We check with the silicone key, and with this step, little by little, we finished all the veneers. No prep veneers for the two central, just a partial prep on the incisal area. It was an aggressive prep on the two canines to become laterals, and a regular prep for the two first premolars to become canines. So it was partial prep, conservative, irregular prep in this case to fix the problem. Then we are going to adapt the veneers on the master model, and it's important the way we are working with the microscope. We always use the microscope. It's not to only use the microscope 8 magnification or 7 magnification or 4 magnification. We have to work with 16 or 20 magnification to get the precision. We cannot talk about 100% of precision. Let's say that we can talk about the less imprecision that we can get in our dentistry. But what we need in the microscopy to see more details to reduce the operative errors. It's an objective analysis tool and more documentation to see more details. So using this instrument, we can see also the initial tooth preparation, the soft tissue deflection, preparation, margin extension, and refining, provisional crowns and finishing, analysis of the impression, and analysis of the framework on the model work, especially when we want to check the fit of the margin, and analysis of the framework in the patient's mouth and excess cement removal when we are working in the mouth. This is what we don't want to see every day, imprecision. Imprecision is very, very, very uncomfortable way to work for the dental technician. The dental technician cannot work with this kind of impression. Most of the dentists, they deliver this kind of impression. They say, I know what I'm doing, so let's do the treat. I know how to cement, how to check precision. You cannot check precision with this impression. This impression is not going to working. This impression is a biological damage when the dental technician is going to prepare the framework on the single coping. It doesn't have the possibility to get the suitable margin with the microscope for the future oral health of the patient. So this is what we needed, a clear margin that the dentists normally work also manually with instrument, nice impression with an individual tray. It's important. The more you do individual tray, the most possibility to get nice impression you have in the future than with commercial tray. And this is what we want to get at. This is the margin. This is the emergence profile that we want to have it here. And when we adapt the veneers, it's not only to get few points, but we have to get a lot of points for the stability of the veneers as well. So let's go ahead with the trying of the veneers. So we had this big challenge that the two canines has to become premolars. We are gonna check the position of the veneers, the fit of the veneers, and we want to see how the soft tissue can react after a while, after the cementation and the precision. So let's talk. Since I said in the beginning, we are working with less imprecision. We cannot say that we are going to be 100% precise. We want to see the biological success, the 100% of the biological success. For no prep veneers, like in this case for the two centrals, the dental technician will decide the margin and has to stay 0.2, 0.3 under the gum. So this was in the beginning. So how the dentist cut the point, the incisal point of the two canines for the patient and told him, okay, you're okay. You have two canines that are trying to simulate a little bit the laterals, but the patient was unhappy. The patient wanted to close the big diastema in the mouth. And so we decided to have no prep veneers or partial prep veneers for the two centrals on the incisal area. We are working with an aggressive preparation on the two canines, and then as I told you in the first part, the laboratory made a bevel in the cervical area of the canine. So this bevel is uncovered. There is no ceramic on top because we want to have a flat emergent profile of the tooth. And we try to reduce the side from the mesial to the distal to get a suitable proportion. The two bulky canines has to become lateral, and the two premolars, the two first premolars has to become canine, and then we try to cover the space between the two centrals, establishing a new incisal position, a new incisal edge. So this is the way we ended up with the case. And it was a very challenging case for us, for me and Dr. Jinho Park. There, I really thank him for his cooperation. And so I really thank you, everybody that are online that can see this presentation. And I give you all my information just in case you have some questions to make it for me. And I hope to see you more in the future with other cases. And I really thank you for your nice attention. Thank you so much.